shall now go on to our next speaker, Dr. Thirumalesh. Dr. Balla will join in a while. And he's a senior consultant ophthalmologist and vitreoretina surgeon from Narayan Netralaya, Bangalore. And let's look forward to see another. And let's see what he has to show us.
Thank you, Dr. Chitra ma'am. I would like to thank the ARC and Dr. Chitra for this kind opportunity to show a cataract surgery despite being a VR surgeon. So my case is straightforward, fairly simple. I hope one can see the video. So this was a 57-year-old female who had undergone a VR surgery for a diabetic TRD. As you can see, when I started, the pupil was small, and I tried to put in a small air bubble and it escaped out. So one learning point is that in a post-vitrectomized eye with silicone oil, there is a lot of upthrust that is going to happen. So putting a pinky would be a good idea. Because it was a non-dilating pupil and a little floppy iris, I had planned that I will put a Malagian ring. You can see that I had made a 2.8 incision and I put the Malagian ring in, which did not directly go beneath the iris. So I used a second instrument to manipulate and insert it. And once I had established a good 5.5 to 6 millimeter exposure of the capsule, I used a cystitome to make a capsular rhexis which was continuous and curvilinear. So I did check by putting some more visco to see it was continuous, and then I did a good hydro to rotate it. So other important thing that one would notice if you are operating cataracts in patients who had undergone VR is that the nucleus, although was giving a good red glow, but it was a pretty hard nucleus. So be a little prepared for harder nuclei, because what appears to have a good glow would not be correspondingly that soft. So you can see that this particular nucleus is pretty hard. And another important thing is in diabetic patients, the central nucleus will be a little more harder than a little periphery. So I employed a slightly peripheral chop in this. So I did a good vertical chop, but a little in the periphery. You can see that the chopping in this particular case would probably yield as something like a flower petal kind of an appearance. So one can also do a little debulking like I did, and then initiate the chop so that it tends to be full thickness. So this quadrant, you can see that the central core is separating from the peripheral area, but the chopping, one can initiate another crack and make sure that it kind of becomes more and more full thickness. It's also to note that once we are operating in post VR eyes, the zonules might be a little weak, so one should not ensure that the pressure on the capsular bag is too much. So once we ensure these things, I think the surgery becomes straightforward and fairly simple. And why one would probably choose a Malagian ring is because it avoids those multiple incisions when you are trying to put in iris hooks, and there can be iris prolapse and repeated iris coming out from there. In a Malagian ring, that kind of gets eliminated, and these floppy irises can be managed well when we tend to put a Malagian ring. One can also use probably the other rings that are there, but this is fairly commonly available with us. So once the nucleus was removed fully, there is hardly any cortex left. You can see that the upthrust is slightly there when we remove the instrument, and some amount of posterior capsular opacification is usually present. So what I did in this particular case was, after finishing the cataract surgery, I removed the Malagian ring, implanted a lens, and when we did the SOR, I also, at the same instance, I also did a small capsular opening.
Okay. We are not able to hear you.
Oh.
Okay.
Now, ma'am?
Yeah, but the last bit we didn't hear. That's okay. You showed us the main chunk of it, and that was again a wonderful video, and a lot of discussions is possible. Dr. Mohan, want to know something very, very basic, but something which all should know. Doing biometric, what are the things which you would give attention to in these silicone oil filled eyes? Like
no, if you have an IOL master 700, then you can go in for that particular formula, the silicone oil filled eyes, automatically it will sing. So please understand that the silicone oil filled eyes, they become more myopic. So the post-operative, they have more hyperopia in the so you need to be, you have to be, because there is a convex oil inside the eye. So you can go in for a fellow eye if you have got access to the fellow eye implantation, and they can do that as well. So normally what we do is we also when we do the cataract surgery, we remove the oil as well. So yeah.
No, but if it is immersion, then we need to remember that we have to change the velocity for
velocity of the yes, absolutely.
So now, does it actually make sense that if you're going to do a pars plana vitrectomy surgery, that keeping in mind that these patients are likely to get cataract, does it make sense to do a biometry beforehand? Your thoughts, expert panel?
What I would say, what we are doing now is mainly a combined surgery. Yes. Anybody above the age of 50, we do a combined phaco and vitrectomy together. And right at the beginning, even if because most of them, they will have some lens changes or nucleus sclerosis grade 1. And when you have a TRD or something like that, then we combine the phaco and vitrectomy together. It makes life easy. And one surgery for the patient, if the oil is there, then after a couple of 3 or 4 months, we just go in and remove the oil as well. So we do a combined surgery mostly, but we do a routinely IOL master and lens star for all these patients, even if they undergo vitrectomy on a routine basis. Yes. So I think makes a lot of sense in that as well.
Yeah. Now, Dr. Thirumalesh, what did you do to open the posterior capsule? They used a vitrector?
Used a vitrector, yes.
Used a vitrector and did it. Now, Dr. Malay, if silicone oil is seen in AC when you're doing the cataract surgery, so what it would it make you wonder about? Like, would you take any extra caution or anything? I mean, this does happen. My thoughts were silicone oil coming in AC, because these eyes who have vitrectomized eyes, they could come with some amount of zonular weakness. So it could also, there could be an inadvertent lens touch and there could be a PC opening too. But if the PC appears to be intact, but the nuclear fragments are very much in the bag, then would you immediately think of putting in a CTR at that point of time? I would want all of you to tell me, any of you could tell.
I would not plan a CTR, ma'am, because many a times there might be a localized area from where this oil might be coming. So you can test that by pushing a little oil, it usually goes back. And until and unless there is no obvious fluttering of the bag, or you have known that there is a zonular weakness, I don't think CTR, I usually do not put, ma'am.
Okay.
Yeah, not routine. See, what happens is oil in the anterior chamber is not uncommon in any patient who's undergone vitrectomy with oil, because the zonules are going to be weak. Through the zonules it will come. Only thing is, the small amounts of oil, you can try to aspirate it and go ahead with the phaco.
I'm not next now.
Yeah. But if you can see the floppiness of the posterior capsule. And once you remove the nucleus, the floppiness of the posterior capsule, that is probably one of the indications that probably CTR may work better in these conditions. The floppiness of the posterior capsule is something which is very, very important, especially when you remove the cortex. In this case, there's not much cortex, more of nucleus and not much cortex. But when you remove the cortex, then every time you remove the cortex, you can see the entire bag. There can be wrinkles on the posterior capsule, and very difficult to remove the cortex as well. And that is an indication for probably CTR, because the zonular weakness can be a little universal or 360 degree in these patients.
Yeah.
Especially in myopes, the brag kind of starts breathing on you. So, when you see that consequently that if the bag at one zone is, fluttering a little more than usual, then probably a CTR would help.
Yeah. But how many of you, with all these challenges, would actually want to go and do a vitrector and open up the PC when the bag could be floppy, when there may be a need of a CTR? Would you want to let the PC plaque remain there and place the IOL? Does that also make equal sense?
Ma'am, can we deal with the plaque later also? Because we can do a YAG later. That's what I was wondering. Is it important to open it up at the time of surgery?
Yes.
Or can we just leave it and deal with it later?
The problem with these plaques is in silicone oil is a very, very thick plaque.
Yes.
Very difficult to do gags.
Yes.
So either you need to cut with the cutter, or sometimes I've done posterior capsular excisions also in these patients. And but you need to use a cutter because the plaques are very fibrotic and very thick and
They're
very
like membranes.
very difficult to use. You need to use very high energy, just like the pediatric capsule. You know, it is like that only. So
Chances of
gag
dislocation
laser
are
is
high.
may not be suitable.
Yeah.
Okay.
I think
Yeah.
with cutter, ma'am, if you use lesser suction and if you can keep the cut rate at about 2,500 to 4,000 and use the suction at about 90 to 100, we can achieve a good round posterior capsular opening.
Okay, very valid points.
Chitra ma'am, regarding this silicone oil in anterior chamber, this actually, once you remove it before doing the phaco, if you even after implanting the lens, this silicone bubble in the anterior chamber keeps coming, and that actually makes some problem while doing the silicone oil remover and subsequent examination of the retina. So what I do is that once I implant the lens, I keep some visco over the area from where the bubble is coming out, so that the bubble doesn't come unless whole silicone is removed from the posterior side, and that makes visualization better.
And a lot of these eyes come to us for management of glaucoma because of the intraocular pressure, the silicone oil eyes. So what is your experience with that?
Usually, we do a early oil removal these days.
Okay.
So,
That is the
emulsification is not there, then trabecular mesh for fibrosis kind of is usually a finding which tends to set in later. So, unless you have emulsified oil with associated trabecular mesh for fibrosis, they tend to do well once you remove the oil.
Dr. Chitra, can I comment?
Give justice to other speakers too. Who wants to comment?
Dr. Virendra Agarwal.
Yes, Dr. Virendra Agarwal. Oh my God. I think we need to see you. What am I doing? I missed you. So sorry.
No, nothing. No, I want to comment on this thing.
Yes,
the silicone oil comes usually from a very small, weak area of zonules. So my opinion, CTR is not required. CTR is usually indicated when zonules are compromised in a larger area, and that too by trauma. Means those are not normal zonules.
Yes.
In this case, the zonules are usually normal, so you don't require CTR.
Absolutely.
Another thing I want to comment upon for glaucoma is that usually the emulsified silicone remains in the angle. So at the end of the surgery, use pilocarpine, reduce the pupil size, and do lots of irrigation aspiration at the angles. So what I do, I am already fan of bimanual. So I do the bimanual irrigation movement all around 360 degree with the irrigation on. So that release some of the bubbles which are there already in the angle. And sometime you require to do the same after 2, 3, 4 days or some days later. You do the aspiration of these silicone oil bubbles from the angle will reduce the incidence of glaucoma like anything.
Yes.
Many patients who come with the glaucoma post-op, you do gonioscopy, and if you find the silicone oil is there in the angles, again do the same AC wash through the bimanual cannulas, and you'll see the wonders in the glaucoma management by removing the silicone oil. Because if silicone oil is there in the angles, it will not let the glaucoma settle. So that is one thing. The another thing that whenever you start cataract surgery, if silicone bubble is disturbing you too much, then you try to let the silicone oil come out as much as can come before doing the cataract surgery. Keep your slightly irrigation on with the bimanual, and some of the silicone oil which is emulsified will come out by that in the antechamber and will get washed out. The larger bubbles will not come and interfere the surgery. So that is my few points for the silicone oil surgery.
Very valuable points. These were the exact things which I had wanted to be brought out, and I'm so glad to have your